morning, everyone. Good morning. Oh, you guys seem tired already? We just started CBC weekend. I mean, the week was okay. Now we're going into the weekend. So good morning, everyone. Good morning. I'm so happy to be here. I'm Congresswoman Sheila Cherfilus-McCormick. I hail from the great state of Florida, and I represent Florida's 20th district, which is Fort Lauderdale and West Palm Beach. And you know, when I came to Congress, I was the CEO of a healthcare company before I came. And as I was the CEO, I saw a lot of people who passed for no reason. We served geriatric, pediatric, and I saw a lot of things that didn't have to happen. And I understood that behind the numbers when we talk about heart disease and these tragedies are families. So I always told everybody, when we talk about one loss of life, that's not an effect of one person. We have to compound it. That could be maybe 5 to 10 people. That's someone's mother, someone's father, someone's daughter, someone's son, someone's colleague who someone depended on and loved. And so we have to look at these tragedies and see what we could do to prevent them. And so when I came to Congress, I said, you know what? I have to use everything I have to do my part. And my part is to make sure that we prevent what we can prevent. So when I came across the legislation for AEDs, I said, this is a no-brainer. So preventable. What are we doing? And then I said, okay, well, we have a Congress which is not so functional, who we have to fight, and who sometimes likes to fixate on fictitious things. And I said, what could we agree on? And I said, you know what? We're all parents. Most of us are parents, right? And so if I could talk to my colleague about something that affects our babies, then we should all agree. And some people said, well, we tried to pass this bill and it didn't move, but you know what? Everybody agreed. These are our babies. When I see your child, that could be my child. And so that's when we went forward with our AED bill. And we realized that let's take baby steps on this. Let's do something that's common sense. What about making sure that every single school has an AED around it? No brainers, very, very simple, right? Just a little AED, every school, and we provide funding. But then one thing I realized as we looked into it and I spoke to parents who had children who died, some kids actually died not because the AED was not present, but they died because the training wasn't present. When you actually see it, you see AED, a lot of people don't know what that means. They're just looking at it like, oh, okay, I guess that's a fire extinguisher. I don't know what this is. And so we realized that it's not enough just to have the devices there, but the training there. We realized that it has to be normalized on how to use an AED. Kind of like when you do CPR, it's normalized now, right? So if we can normalize it and put the training there, we can save lives. One of the highest rates for kids dying who play sports, cardiac arrest. We could prevent that. So we went forward and we put this bill, we got support. And we couldn't have done it without everyone who's here. So I'd like to thank every single one of you who are here today and the American Heart Association. I'd like to thank you guys also. And what I say is that, you know, we fight every single day, but when you guys are fighting with us, it bubbles up and people realize that this is real. This is impacting all of us. And so I'm sure you guys know the stats about what we're dealing with here, but I'll share some also with you. As you may know, sudden cardiac arrest remains a public health crisis in the U.S. with over 356,000 cardiac arrests occurring outside of the hospitals annually, 90% of which result in death. Sudden cardiac arrest can strike anywhere without warning in our homes, in our schools, in our campuses. There's one more thing I wanted to point out, that our athletes are 3.5 times more likely to experience sudden cardiac arrest than their peers. And the reason why I wanted to point that out is because a lot of us think in our communities that sudden cardiac arrest happens to people who are healthy. Not our kids, not our athletic kids, who are some of the best, who are running. We would never expect that to happen to them. But that is our reality, and that's what we have to make known to everyone. Because when I spoke to the parents and the families who lost their children, no one saw this coming. Did we see it coming when we were watching football? Did we see that was going to happen to DeMar Hamlin? He was in great shape. Nobody knew. We didn't see it happen even when we heard about what happened to LeBron's son. I mean, they had the most of everything. You would think that he's the most healthiest person because you grew up in privilege. But it happens. And so we need to tell parents that this is real, and we need to keep putting legislation to teach them and to help them. And I think we need to go a step farther and figure out, how do we prevent it? Why is it happening to our student athletes? And so that's the next step as we get this passed. I believe that next week we should be voting on it, and it's going to be a suspension bill. And so we're so proud for that accomplishment. That wouldn't happen without you guys who are here today. So thank you. And let's continue to move this thing forward. How do we prevent it for our babies? What is really going on? Let's take some studies and figure out how can we stop them even from being in that situation. It should not be 3.5 times more likely. And so as we go on this train together, on this mission together, as we move forward in this destiny moment that I tell everybody about, and I believe because we're showing up here on this day, so Friday at 11 a.m. when we could have been at any kind of other events, we're showing our dedication. And it makes me very proud, and I know that we'll not just only meet this moment, we'll exceed it. And so when we all grow older and we're looking back and we're like, do you remember when they used to have this problem where kids used to die of cardiac arrest? And people will think about it as some foreign thing that happened long ago, but we know we fought to make sure we ended that. So thank you everybody for being here today. Thank you the American Heart Association for having me. And I look forward to seeing you guys throughout the weekend and even seeing you guys at some of the parties. Have a good day.
Good morning, everyone. My name is Dr. Yolandra Hancock. I am a double board certified pediatrician and obesity medicine specialist. I serve on the American Heart Association Greater Washington Executive Board. It's my pleasure to be here this morning to have this very important conversation. What I will do is introduce each of our panelists, our esteemed panelists, as we discuss a very important issue. The American Heart Association recently provided data that showed that women and people of color during a sudden cardiac arrest are less likely to receive bystander CPR and are less likely to receive AED intervention, thereby increasing our risk of death at that time. And so what we have here is an amazing panel of experts that are going to talk through the data and really explore why that is happening. My first panelist on my far left is Dr. David Goff. I'll give a little bit of information about this amazing physician and PhD, absolutely. He is the director of the Division of Cardiovascular Sciences at the National Heart, Lung, and Blood Institute of the National Institutes of Health. He received his MD from the University of North Carolina and has a PhD in epidemiology from the University of Texas Houston School of Public Health. He trained in internal medicine at Baylor College of Medicine in Houston, and he has published over 300 manuscripts, book chapters, and other scientific reports. The one that stood out to me is the study from the Cardiovascular study, which is a longitudinal study looking at people of color over 30 years in order to collect data to have a better understanding of how communities of color are impacted by heart disease. So I want to turn it first over to you, Dr. Goff.
So thank you very much. It's a real pleasure and honor to be here this morning with all of you to talk about this really important issue. And I want to start by bringing greetings from my Institute Director, Dr. Gary Gibbons, who wished he could have accepted the invitation, but he was committed to other activities today and asked me to fill in, and I'll do the best I can to represent Dr. Gibbons at our Institute. I do lead the heart part of NHLBI, and that's been a real pleasure for me over the past 8 years or so. Just to give a little bit of my story, before I came to NHLBI, I was in academics where I was practicing medicine and doing research and teaching, and also have a second full-time job as an AHA volunteer. So the love is strong and deep for the Heart Association for me, and I just couldn't be happier to be here with you today. Now that I'm at NHLBI, I'm really pleased to be part of that mission. Our mission is to provide global leadership for prevention, research, treatment of heart, lung, blood, sleep conditions, so that all people can live longer and more fulfilled lives. And that's a really wonderful mission that I get to work with a great group of people. In our strategic vision, we have 4 overarching goals. They are to understand human biology, reduce human disease, advance translational research, and really support the workforce and the resources that are needed for that workforce to be successful. But that's our vision, and a vision without a plan is only a daydream. And so we put together an implementation plan for our strategic vision in my division of cardiovascular sciences about 6 years ago now. And we have 6 pillars for that. I think it's important to share that with you. The first pillar in our strategic vision and implementation plan is addressing social determinants of cardiovascular health and health inequities. It was first for a reason, because until we do that, we won't make progress on much of anything else. And the first word is really important. It's addressing. It wasn't understanding, it wasn't learning more about, it wasn't studying, it was addressing. And so we, in our mission and in our strategic vision implementation plan, our first pillar, addressing social determinants of cardiovascular health and health inequities, really makes this meeting today right squarely in the middle of what we do. So I just wanted to provide those a little bit of context, and then I'll talk a little bit about the papers that I've been asked to review. They come from research that we have funded. So first, it's important to know from some of our research and cohort studies like Cardio that we learned that African Americans are twice as likely to experience sudden cardiac death than non-Hispanic whites. So let's start with that. The burden is twice as high. When it occurs, research we've supported has published that African Americans are less likely to get CPR. At home, it's about 40% versus about half of non-Hispanic whites. In public places, it's about 45% as opposed to about 60% of non-Hispanic whites. So twice as likely to have an arrest, less likely to get CPR. Then this most recent paper that we're highlighting this morning talks about the effectiveness of the CPR when it's given. And it turns out less effective. We don't know why, but what we've learned from this paper is that when people have a cardiac arrest outside the hospital, it's witnessed, and they don't get bystander CPR. Somewhere between about 6 and 8% of those individuals live to go home. That's not good. With CPR, it increases to somewhere around 9 to 14%. That's still not very good, but it's better. And every one of those successes is a miracle for that family and that individual. But what we learned from this paper is that the benefit of CPR is less for women than for men, and less for African Americans than for non-Hispanic whites. We don't know why, although people have some reasons that they speculate. They speculate around issues of maybe a little bit of fear. Maybe there's a little bit more fear about giving CPR to women or to women than to men because of concerns about propriety or touching women in that part of the body. Now, you know, if the alternative is that someone's highly likely to die, I think we need to help people get past that fear. You know, there's speculation about the differences between African Americans and non-Hispanic whites being related to maybe the neighborhoods, but in this study, they looked at characteristics of the neighborhood in terms of people who lived there and the wealth of the neighborhoods, and that didn't explain it. So they also speculate that maybe it's something to do with the quality of the CPR and the training that the individuals had who were giving the CPR, or maybe some of the support that they were getting from emergency medical services. You know, if you call 911 and the ambulance is on the way, the dispatcher will give instructions to the person at the site about how best to do CPR, because not everyone's trained, and even if you're trained, your heart's racing 1,000 beats a minute, your mind is a little bit confused in the moment. It's helpful to have somebody reminding you of what you should be doing and how you should be doing it in the heat of the moment, as you might say. So we need to learn more about why CPR is less effective when delivered to African Americans and to women than when delivered to whites and men, because we don't really understand why that is the case. But I also want to kind of close my session here by going back to the beginning and saying that yes, 350,000 or more out-of-hospital cardiac arrests every year, twice as likely to happen for African Americans as for non-Hispanic whites. and the survival is not good even with bystander CPR. So we need to do more to prevent sudden cardiac arrest in the first place. We need to pay attention to that too. The topics we're talking about here this morning are critically important, and we need to do more to prevent cardiac arrest in the first place. It's through things like preventing high blood pressure and controlling it better, preventing smoking, preventing diabetes and controlling it better, preventing high blood cholesterol and controlling it better. There are important inequities in all of those conditions too that we also need to address, while we also address a really important issue we're focused on here this morning. So thank you for having me.
Thank you so much, Dr. Goff. Can we give him a round of applause? Next, we have Dr. Chidinma. Sorry, I'm mispronouncing your name. We went through it and I still messed it up. She's the Associate Director for Stakeholder Engagement at the Johns Hopkins Center for Health Equity. She's also an Assistant Professor in the Department of Medicine. She received her BA from the University of Pennsylvania and her PhD from the Johns Hopkins Bloomberg School of Public Health, also my alma mater. She is doing amazing research in community engagement in healthcare, patient activation, intervention and communication, health disparities, and social justice in healthcare. She is truly a trailblazer in work with community health workers as they assist communities in navigating what can be a very challenging healthcare system. Dr. Ibe, I can't wait to hear from you.
Thank you so much, Dr. Hancock. And before I start, I just first want to thank the American Heart Association for inviting me to be part of such an important discussion with these esteemed panelists. And I also want to thank the panelists that spoke before us. I think as a researcher, we often acquaint ourselves with the numbers and the statistics, but to see the stories that underlie these really troubling patterns that we've observed when it comes to cardiac arrests and the low incidence of bystander CPR is something else. And when it said, I think it described that panel as bravery, and bravery is definitely the correct word to describe what it takes to share your personal journeys and do so in a way that really illuminates what this actually means for people's lives. And we know that when one person passes, it's a cascade of just devastating feelings and experiences for people to navigate. So I really do want to thank you so much for using such a heartbreaking situation and turning it into good. I would be remiss if I didn't start off saying that. So, but yes, when I read this study that we're going to be discussing this morning, as a Black woman, I found it very troubling. As a researcher, I found it very troubling. And one of the things that stood out to me is that when they conducted additional analyses, they actually found that the effect was worse for Black women. And so when we think about this joint impact of race and ethnicity, as well as sex on bystander CPR administration and cardiac deaths, it really indicates that when CPR is administered, Black women are still less likely to benefit from it. And there are several different reasons why this may be the case. And I was curious, I didn't understand what some of the factors were. So I did a bit of my own little Google Scholar search just to find out if others had explored this in greater detail. And I greatly appreciate the work that Dr. Goff has advanced in this arena, as well as his, what he mentioned earlier about areas for further research. But just this notion that some people are afraid to administer CPR because of a host of reasons. Sometimes it's even broader mistrust in medical institutions, broader mistrust in calling for emergency services and fearing that it will be in vain in essence. And so how do we dismantle some of the factors related to mistrust that are grounded in realities, that actually make a lot of sense when you think about the issues that minoritized communities have had in terms of access to care and their experiences accessing care. But again, enlisting trusted leaders, maybe even launching campaigns that are going to help alert people to all of the different facets of CPR and its importance, that to me seems like a critical strategy. And then to close and integrate what Dr. Hancock mentioned earlier regarding my research, I focus a lot on community health workers. And in case you don't know who they are, they tend to be people from communities that struggle with various health inequities, and they have lived experiences that allow them to serve as a liaison between members of those communities and health and social service systems. And one of the things that I've loved about working with community health workers is that they are themselves so passionate about doing things that empower the communities they work with. And I believe that they're an untapped resource when it comes to disseminating best practices in CPR, as well as education around preventing cardiac arrests, which Dr. Goff addressed earlier. So I'm really looking forward to further discussion and to hearing more from what other, those of you in the audience as well as the other panelists have to say about this topic, and I appreciate your time.
Can we have another Dr. Last but certainly not least, Dr. Yvonne Commodore-Mensah. She is a renowned cardiovascular nurse epidemiologist with national and international recognition. Come on, sis. Her research focuses on reducing cardiovascular disease risk among African populations across the diaspora in the United States and in Africa through community-engaged research and implementation science.
I should invite you to introduce me every time I talk. Good morning, everyone. It's such an honor to be here. I'm Yvonne Commodore-Mensah. I'm an associate professor at Johns Hopkins School of Nursing, and I have a joint appointment in the Department of Epidemiology at the School of Public Health. Relevant to our conversation today, I'm an AHA volunteer, and I've been for 13 years. If anyone knows the AHA, once you get hooked, connected, it's for life, right? So I'm currently board member for Maryland and the greater Baltimore area, and most recently the Eastern states. So that connection to AHA is getting deeper and deeper. So first I'd like to thank the organizers and especially AHA for inviting me to be here. As you said earlier, I'm a nurse, and it's nice to meet another nurse. Patrice, thank you for telling your story. Thank you for turning your pain into purpose. As you spoke, I think I shared with you, I fought back tears because I too have a son who has a similar build, and I know he's going to be 6'5" plus, and he is into sports. So thank you for telling your story and inspiring us to act. So as a nurse, I work at an Fairfax hospital, and I cared for a lot of patients with heart conditions, so heart failure, and over and over again, the patients who would keep coming back were Black people. And so I started to ask questions. And growing up, I got into a lot of trouble for asking too many questions. And one of those questions was, why? Like, you know, what is it about Black people that makes them more likely to have these conditions? And people were surprised that I was asking because I'm Black, if you haven't noticed. But I wasn't born here. I was born in Ghana, West Africa. And so I wasn't privy to the history of America and the reality of what is the healthcare system today and what it used to be, and how people did not show up to the healthcare system because of concerns about treatment. And there was a point in time that people were not allowed to show up to certain hospitals. So these were things I had to learn along the way. And so I was committed to doing something about it. So I went back to school to pursue my PhD. And when I took classes in epidemiology, over and over again, it was cardiovascular disease epidemiology. So I think Dr. Goff knows where this is going. So every week we talked about a cardiovascular condition. So hypertension, diabetes, kidney disease, you name it, every condition. Black people are more likely to have X, Y, Z. And so again, I said, gosh, is there something about our skin color that makes us more prone to these conditions? And I realized that, fortunately, skin color has been used as a proxy for race. And when we think about race, it's a social construct, right? So the biological basis for these conditions were not there. I said, I've got to do something about it. So I spent the first half of my career conducting studies to understand these disparities. And lo and behold, I think it became clear that social determinants, right? It's not skin color. But pre-COVID, I think we used to be very creative about how we talked about disparities, right? And called out racism. I think AHA did something bold in 2019, or it was 2020, where AHA named structural racism and actually used the R word. All of us were stunned, right? That AHA took this bold move to name structural racism as a root cause of these disparities. And so beyond describing these issues, we know that we have work to do. And how do we do this work? Two ways that I've committed to. One is implementation science. The evidence exists when we think about how to prevent, control heart disease, but community engagement is one of them. And it became clear to me that being a bedside nurse is beautiful, it's amazing, I miss it. But in terms of population-wide impact, I realized that I want to be part of teams that create programs to increase awareness of heart disease as a risk factor. So one of the studies we conducted a few years ago was to look at national data to understand disparities in awareness of heart disease and also the signs and symptoms of a heart attack, and when to call 911. This is the National Health Interview Survey. We compared white Americans to immigrants from all over the world in the United States. And lo and behold, we learned that immigrants were less likely to be aware of the signs and symptoms of a heart attack, and they were less likely to know when to call 911. So as we think about these disparities too, I think it's important to acknowledge that beyond race, there are pockets of populations in the US who need to hear this message, who need to understand that what the signs and symptoms are, and relevant to the paper and women. I think it's always amazing when we talk about the signs and symptoms of a heart attack. And for men, right, it's chest pain, but for women, very few women actually know that heart disease is the leading cause of death. When you ask them, they say it's what? Cancer. We're more fearful of cancer than we are of heart disease. Right? So for women, and we use the term atypical, right? So men have the typical symptoms, and we women, our symptoms are atypical or not typical, where it's nausea, vomiting, tiredness. That one's dangerous. I don't know any woman, any mother who is not tired on any given day. So you're more likely to what? Ignore these symptoms. But what happens when you actually show up to the healthcare system? Are you listened to? One, do we listen to Black women? We don't, right? So we think about how and why people may delay, right, in presenting, or how we can improve response times. We just need to acknowledge that they say men are from Mars, women are from Venus, but just acknowledge that we need to educate differently. We need to reach people in faith-based settings, in communities, salons, right, where women are, right? Increase the awareness, but don't ignore your symptoms. And sometimes I think people are not ignoring their symptoms. If you're a care provider, you're caring for your child, your parent, right, and you have symptoms, you're more likely to start thinking, now, what am I going to do about these other people? And not prioritize your health, right? So there's a lot of work to be done, and I look forward to the dialogue. Thanks.
Yes. Excellent. That was amazing information. What I gathered from each of you in your own areas of expertise, Dr. Goff did an amazing job of setting the tone in terms of providing us with data and historical context and helping us to look forward in terms of what our next area of research is. And you did such a phenomenal job of pitching that out of the park by talking specifically about the research that you do, Dr. Ube, and how it connects in us moving forward to address this specific issue. And Dr. Commodore Mensah, you just capped it all perfectly by giving us a very detailed public health lens in how we see it, and really discussing the intersectionality between women our race, and then our immigrant status. So thank you so much. What I first want to do is open the opportunity up for our audience to ask any questions before I bombard them with the questions that I have thought about as I've listened to them in their brilliance.
Thank you all for what you presented. I am truly appreciative of everything that you all had to say. I don't know if you all were here earlier when I stated that I'm a 5-time heart survivor. Dr. Yolandra and some of the others in the room have seen me around for a very long time. And all the work that you're doing with research and all of that. But this is geared directly more to the 3 women in front of me right now, is because Dr. Yolandra, you hit on it, and so forgive me for forgetting your name. But my situation at the time, I had my first episode at age 46. I'm 61 now. And I was turned away from hospitals in the DMV 5 different times, saying nothing was wrong. So with all the research and everything that you're doing, that's great. But how do we really analyze to keep women from dying? I understand that clinical trials weren't done until 1979 on women and all of that other stuff like that. But I had a family history, and this is not an excuse for lifestyle or anything like that. And as you mentioned, forgive my pointing, I didn't have atypical symptoms. I didn't have high cholesterol. I didn't have high blood pressure. I was not overweight. But I knew my risk factor because all the men on my father's side of the family died before the age of 50. My father survived because he had quadruple bypass surgery. So that was the advancement of modern medicine. My sister, who is 17 months younger than I, also has heart disease. She lives with about 7 stents. I've had double bypass surgery. My first cousin, 28, suffered cardiac arrest. Fortunately, she survived. So I'm saying all that to say, when we go to the hospital, how do we get them to take us seriously? Because what happened, I refused to leave on the 5th time because I knew something was wrong. They had sent me on one of the trips to get a stress test. And as you said, it didn't reveal anything. I had the lipid profile, I had the carotid Doppler, I had all of that. Yet, none of them thought about doing a cardio cath. And so, it was the blessing of God that when I refused to leave on that 5th trip, one of the cardiovascular doctors that was in the ER saw me. And he recognized me. He said, Ms. Harrisbury, what happened to you? Because by this time, I was so haggard, I could hardly put one foot in front of the other. I was holding on to the wall, moving, and I knew that something was wrong. And he said, we've done everything for you. Some of those tests we've already done 2 or 3 times. There's nothing that we can do for you. You're going to have to leave this hospital. And then they sent down the psychiatric ward saying that I had mental problems. I said, I assure you there is nothing wrong with my mind. This particular doctor, he said, well, the only thing I can offer you is a cardio catheterization. I wasn't as astute as I am now as it relates to heart disease because I've been with AHA a long time. I said, I don't care what it is, I want it. When they wheeled me up to the lab, while I was under, all of a sudden I could hear them saying, hurry now, get this, come quickly, now. So when they were wheeling me to recovery, I told them, I said, I could hear everything that you said. What was it? He said, you had a 90% blockage and this would have killed you. A few years later, I went in for an absorbatory cath to make sure that my stents were working. Released to go home and bled out. I spent 3 weeks in a coma. The doctor said I wouldn't live. All the blood drained from my body. They had to clamp my aorta to force blood to my brain. I had 7 blood transfusions and 4 surgeries. And in the process of them trying to save my life, my lower intestine was perforated and sepsis poisoning. But I'm here to tell the story. So my thing is, when women go to the hospital, how do we ensure that we're taken seriously? Because we can prevent death and dying if we're just taken seriously. Even when you know your risk factors, even when you're taking the statins, when you're doing everything that you know to do. But when you have to go to the hospital, how do we ensure that you are taking us seriously?
I first want to just be in that moment before we collectively answer the question. Often in these conversations, we don't get to have those kinds of real moments. And I feel you, sis, I see you, sis, and I hear you. I think it's hearing your story. It's medical students. It's residents. It's physicians. It's public health professionals. It's researchers. It's policymakers. It's everyone who's in this room and beyond needing to hear your story, because we often hear a glimpse of it, and it's usually that the person did not make it. It's in memory of, right? As opposed to being in the space of a living, breathing, walking, talking miracle. And so, I start crying myself, because I feel the energy and the God presence that you bring every time I see you. I think it's in how we have historically not listened to Black women. I often say that Black women are the birthplace of all of us. They are the collective mother, and we often don't listen to our mommies. And so it started from the beginning of time, but it is time for our voices to be heard. Amen. We now have elected officials, and prayerfully we will have a first lady in office, right? We'll have a Madam President in office, as a matter of fact, who will facilitate some significant change. But I think it is how we perceive our patients. It is only because of personal experience I often think that I am more in tune to what happens in my community as a Black woman. There are Black physicians I have seen who have not listened to me as a physician. And so it goes beyond race, it goes beyond class. There is something that happens in medicine day in and day out that sometimes makes us a little immune to the patient experience. It makes us numb. There have been times I've had to check myself after a 36-hour shift on that 35th hour of listening to a mom or dad. Am I listening? Am I really listening? And I sometimes will apologize. My love, I've been working for a day and a half. I'm tired, but you deserve my presence, my attention, my thought, and my consideration. And what I would tell you as a daughter, having had to advocate for my mother, who they were about to discharge after she had a stroke, I don't stop. We joked earlier, I'm a Leo, an alpha female, and I'm from Louisiana, so you don't get all this hot sauce. You do not stop. And if you are of the personality, you are an introvert, you do not feel comfortable advocating in this space because you are a gentle spirit, you bring the fire with you. And any healthcare professional that says you can't bring anyone with you, you find a different healthcare professional, because I believe in bringing your village.